This is Dr. Kenneth Lewis, and this video is for patients who have been scheduled for medial branch blockade testing that may precede a radiofrequency ablation neurotomy treatment of innervations to painful joints. With this procedure, we can treat anywhere from the tailbone all the way up to the base of the skull. And what we're specifically talking about for most of those treatments is treating the actual facet joints. So if you look at the lumbar spine off of the base of this model, the front of the spine moves because the discs are rubbery and they bend, but the back of the spine is like an accordion of bone that can open and close depending on how your spine moves. Each one of those joints is a true joint. It's got cartilage on both sides. It's got a little bag around it. It's filled with fluid, and they're meant to glide and slide past each other comfortably. But for some people, they can get arthritic changes within those joints or multiple joints that can cause the specific pain that they're being referred to have treated. There's no way to look at a fancy MRI or X-ray and see the arthritis to a degree that we can be sure which, if any, of the joints are actually the source of your pain. The only way that those joints can be evaluated is to evaluate the joints directly with interventional pain management. There's two different methods that can be utilized. You can try to put the medication within the joint like you would with a painful knee, but a knee joint is very large. The size of the facet joints is very similar to the space between my fingers when I'm rubbing them together, and there's just not much space to put fluid, even if you can technically get a needle in that space. So what we do instead is we treat the small little nerves that go into the joint, and they're called medial branches, which is why you're scheduled for a medial branch block test. There's big nerves that leave your spine that travel down your legs or down your arms, depending on where you are in the spine. We're not treating those nerves. We could, but they would just make those nerves go off to sleep. What we're doing is we're turning off the small little branches that come posteriorly out of that root, and all they do is innervate the surface area of the joint and send sensations of pain from that joint. So if that joint is the source of your pain and we place a small amount of numbing medication right on the root that goes to that joint, your pain will be gone, and that is the test. Typically, we won't treat one joint. In my practice, it's typically 4 nerves, either on the right side or on the left, or occasionally on both sides. That allows us to take a certain segment of your spine where you're having pain and have the best chance of having a successful treatment if that is the source of your pain. So on the day of your medial branch block, you'll come in. We will encourage you to have an IV, so you'll need to have a driver. On that day, once the IV is in place, we'll bring you back to the procedure room. It will place you face down on the bed and clean off your back. The needle that we're using is so small that a numbing needle would cause more pain. So this very small needle is utilized to go through the skin and very carefully maneuver that needle down to the small medial branch, which we can watch under fluoroscopic guidance. Once we've touched that little nerve, we'll place a small amount of contrast so I can make sure that there's not a blood vessel there that's carrying the solution away. Once we can verify that the solution is staying on the medial branch that we're testing, a very small amount of local anesthetic will be placed on that nerve, about enough anesthetic to fill about half of a Q-tip. We do not want to numb your back. We simply want to numb that one very specific root that goes to that joint. So on a typical low back test, we will numb 4 nerves that go to the bottom 3 joints. The moment that I'm done, those 3 joints on your lower spine are completely off to sleep, but everything else in your low back is awake. The sacroiliac joints, the discs, the spinal cord, the roots themselves, all of those are awake. It's only the medial branches to the facet joints that are off to sleep. And we're going to document while you're active with activities that would typically precipitate your pain, whether or not a significant amount of your pain has been treated. If we find out that a significant amount of your pain is gone, then we will schedule for a confirmatory block where the same procedure will be performed again with simply a different local anesthetic. The only difference with the local anesthetics is how long they last. We still expect very high quality pain treatment regardless of the duration of action. But if I have 2 injections that give high quality pain control, and we frequently see 80, 90, or 100% better, then the conclusion will be that it would be nice to have those nerves stay off on a regular basis, because you do not lose any other function when those nerves are off, simply the ability to feel pain from those joints that are otherwise doing their job successfully. We would just like them to do that job without sending pain signals. So if we have 2 successful blocks, we'll bring you back in for the actual treatment day. On that day, you'll once again be provided with some light sedation, placed into the prone position. This time we'll numb the skin because a slightly larger needle will be utilized, and we'll guide that needle right down to the same nerves that we've already tested twice, and we'll anesthetize it with local anesthetic again. But this time, while the nerve is numb, we'll leave that special radiofrequency probe right on that nerve, and heat the tip using radiofrequency, which is basically like a small microwave. We vibrate the water molecules at such a high frequency that they heat the tissue up to just the right temperature that nerve tissue, which is very delicate, just is removed. Now we're going to remove a very small segment of nerve, so now that the joint won't be able to talk to the brain, not because it's numb, but because there's actually a segment of nerve that's missing. That nerve will remain missing until it regrows, and that for many patients can take many months up to a year, sometimes many years. But it's the longest way to control pain from those facet joints without major surgery, such as a spine fusion. This is a very successful procedure in my practice, but requires the diagnostic precision to be accurate before the radiofrequency treatment can be utilized. Now, this treatment can be used to treat the nerves that go to the sacroiliac joint, and there's 1, 2, 3, 4, 5 nerves that go to the sacroiliac joint. It can be used to treat the nerves that go to the facet joints at the base of the spine. It can be used to treat the nerves that go to the thoracic facet joints, and of course, finally, the nerves that go to the cervical facet joints as well. All of these will require initially the medial branch blockade testing, and if successful, that can then be followed with the radiofrequency ablation neurotomy treatment. If the radiofrequency ablation neurotomy treatment is successful at treating your pain, it is anticipated that at some point in the future, those nerves are likely to reinnervate. With sacroiliac joint treatments, I occasionally have treatments that will last for 5 to 6 years, but the typical patient is anywhere from 10 to 14 months before those nerves need to be retreated. If you have a successful treatment with the radiofrequency ablation neurotomy and the nerves regrow a year later, you do not have to go through the medial branch blockade testing again. We simply bring you back in, and typically anywhere from 15 to 20 minutes later, we can have those nerves retreated with the radiofrequency ablation neurotomy once again. If that is the main source of your pain, then that procedure can be utilized as often as necessary because it's not a steroid that we're using, it's just local anesthetic and heat. So if you're scheduled for medial branch blockade testing and radiofrequency ablation neurotomies, that's what you can anticipate on that day. All right, thanks.